مش شغال. اوكي اوكي بس انا عايزه انزلها تاني. لا مش تطلع على الشاشه ليه؟ كده خلاص كده. I'll talk about the common pitfalls in MRI of prostate cancer. We face a lot of common pitfalls in prostate cancer, and why? Before I reply for this question, I want to say something, that the PIRAT system has made it possible to standardize imaging interpretation and reporting for prostate MRI. Although the existence of a standard protocol significantly helps the radiologist in interpretation and reporting, prostate MRI imaging is not free of diagnostic pitfalls. And why it's not free from diagnostic pitfall? Because MRI of the prostate, as Professor Rouge said, it's a complex examination, has multiple different sequences, and each sequence has its own artifacts. And second, because the prostate anatomy itself is also complex and variable from one patient to another, and confusion with normal variants is, sorry for that, okay. اوكي سوري. ايه ده بيعمل كده ليه؟ مش مظبوط خالص. سوري. في حاجة غلط. Sorry for that. في ايه غلط؟ في ايه غلط؟ اوكي. And the confusion with the normal variants, تحت كده تحت okay. And the fusion and the confusion with normal structure and similar benign conditions. And we can say that it's critical to be aware of these limitations, as false positives and false negative MRI imaging results can lead to over or under treatment respectively. And these pitfalls can be collected as examination quality pitfalls, number one, or mimics interpretation in pitfalls, and number three, in susceptibility pitfalls. To start with the examination quality pitfalls. This is one of the most important problems facing us in reading the MRI of the prostate. The examination quality pitfalls, all of us wants to see the MRI like this, a very good anatomy, showing the glandular tissues, the three zones, the peripheral zone, the central glands, the fibromuscular stroma, and different levels of the prostate at the base, and in the mid-gland and the apex. And we want to see the glandular tissues and non-glandular tissues with its ratio. However, that's why they are putting something known as the PI-qual. PI-qual is a PIRADS, but it's PI quality. So assess every single sequence, and at least in each sequence it should be required at least 3 points from these 4, as Professor Barnes said. In the T2 weighted images, at least the anatomy is well seen, the prostatic structures is well defined, and there is absence of severe artifacts. This is a good one. In the diffusion weighted images, signal noise ratio in B values is good, and in the ADC, there can be identified the transitional zone from peripheral zone on the ADC mapping, and there is absence of artifacts, and diffusion weighted images in plane with the T2 weighted images. This is a good quality one. And for the DCE, dynamic contrast enhancement, image quality that allow assessment of the different prostatic structures, and you can see also identify the anatomical structures, for instance, the pudendal arteries. So such exam, good quality, so a good interpretation of the prostate MRI. That's all what we want to see in a good exam for the prostates. We want to see a good T2 weighted images, in plane with the diffusion weighted images, the high B values, and in plane also with the ADC, where the cancer can be seen as low signal intensity in T2, and the restricted diffusion in the diffusion and low in ADC. Another case, that's the quality of the exam, what we need. So not to do a lot of false positive or false negatives. This is a good T2, a good diffusion B value, a good ADC, and a good contrast enhancement. The second pitfall is the interpretation. A lot of mimics of interpretation pitfalls include Some of them are normal variants of the prostatic glands, like the central zone, anterior fibromuscular stroma, periprostatic venous plexus, and others related to BPH nodules, ectopic BPH nodules. Others because of the biopsy is taken before the MRI, post-biopsy hemorrhage, or the most important mimicker is prostatitis. All of these cases are of low signal intensity in T2, but this is prostatitis, and this is hemorrhage, and this is scarring, and these others. Let's start with one of the normal variants or normal anatomy of the prostate, the central zone. Central zone appears in T2 weighted images, can be identified to 80 to 90% between the peripheral zone, transitional zone. If we see this is axial T2 weighted images, this is the transitional zone, this is the central zone at the base of the gland, and this is the peripheral zone of high signal intensity. The ejaculatory ducts are encircled by the central zone, which extends from the base till the middle 1/3. So our landmark is the ejaculatory ducts. In coronal planes, the central zone looks like Mickey Mouse ears or water drop, and it's low signal intensity T2. The problem is it may show some mild restricted diffusion. This is the central zone in the axial and in the coronal, and the absence of early arterial enhancement help us, or it may exert type 1 progressive enhancement. The problem is that the central zone show asymmetry in 80% of cases, mainly when the BPH is included. In such a case, for example, this is a normal case, but you see the central zone, it's really asymmetrical on the left side. It may mislead us that this is a prostate cancer, and it shows some restriction as well in the ADC. However, this is a normal central zone. While in here, there's asymmetry in between this left side of the central zone on the right side, but the presence of, this is not a normal central zone. Here the asymmetry because of abutting of a prostatic cancer, which gives us a very low signal intensity in the ADC and high signal intensity diffusion weighted images. And the problem is the tumors in the central zone are more aggressive and show higher Gleason scoring and sometimes reveal the biochemical recurrence after treatment. So take care of the central zone. Another normal variant, the presence of normal anterior fibromuscular stroma, but sometimes this normal stroma hypertrophy. Where is this anterior fibromuscular stroma? It's in the anterior part. It looks like a crescent of low signal intensity. Thank God it's low signal intensity in all pulse sequence. It's low in T2 weighted images. It's low in the diffusion weighted images. It's low in the ADC. However, one of the important things as well, it has a concave borders in the T2 weighted images. When this concave border is lost, take care, it may be a tumor. And the ADC, the fibromuscular stroma is composed only of connective tissues and muscles without any glandular tissue. And due to its low signal intensity T2, it can mimic cancerous lesion, particularly when it is asymmetric or not crescentic. In this case, no, this is not an ADC. This is not an anterior fibromuscular stroma. This is show restricted diffusion and show low signal intensity in ADC. This is a big tumor in the anterior part of the gland. Another mimic of the normal variants, the presence of periprostatic venous plexuses. Periprostatic venous plexuses is a normal anatomy, and it is seen along the lateral aspect of the gland, and they can display low signal intensity in T2 weighted images, and so it mimics cancerous focal lesion. Occasionally, it may exhibit also mild restricted diffusion, like this one. This is an ADC, this is a diffusion weighted image, and it shows restricted diffusion on the lateral aspect of the gland. And along with focal enhancement in dynamic contrast enhancement, these findings may mimic clinically significant PSCA. However, tracing the periprostatic venous plexus and they become as like a tubule will give us and help us to differentiate it between it and the cancer. So this is another variant. And then we go to the transitional zone. BPH transitional zone is really very common, and every man after 50 years old most likely is complaining of BPH nodules. And we have a very big spectrum of the benign prostatic hyperplasia nodules, and they are not all the same. Sometimes they are cystic, sometimes glandular, sometimes stromal, and sometimes even take care not to be tumoral. In the cystic condition, it's easy. It's a high signal intensity T2 weighted images, no restricted infusion. In the glandular tissue, this is the typical nodule that we know. It's like it's encapsulated and well defined and show low T2 signal rim all around and no restricted diffusion. But what about the stromal tumors, the stromal nodules? The stromal tumors is always atypical. It shows low signal intensity, and sometimes it may not be completely encapsulated, or the rim is deficient, and sometimes as well do a restricted diffusion in the ADC images. So this will give us a conundrum, a difficulty to take care. It's not a tumoral nodule like this one, being ill-defined, lenticular, and show very low restriction, low signal intensity in the ADC images. BP nodule may mildly or moderately restrict diffusion and appear bright in high B values and appear dark in the ADC map, and show rapid enhancement, sometimes without on the DCE feature that may resemble cancerous tissues. Also, the BPH nodule may become ectopic. What do you mean by ectopic? This is give us a diagnostic conundrum. Sometimes it protrudes like this from the transitional zone, but is still connected to the transitional zone. Sometimes it's extruded into the peripheral zone completely away from the transitional zone, but still looks like a BPH to me. However, when it's really extruded away from the transitional zone, it looks like a tumor and gives us a problem in differentiating it and necessitate biopsy. Here it is. This is a coronal fat sat T2 weighted images in which this is a very good typical nodule of the BPH. And while here it's just only protruding, here this is extruded from the central gland. Take care, this is not the same. This is a really suspicious lesion. However, it's still encapsulated. It's important to remember that tumors with pseudocapsule has been documented and may be related to high-grade malignancies. Another case of our cases, this is an extruded or protruded PP nodule, normal, but this is not. This is a cancer. Another problem and issues with the urologist is the post-biopsy hemorrhage. Oftenly, we receive the patient after it already took the biopsy by transvaginal guided biopsy. And the hemorrhage and the blood can last for a long time if biopsy was taken before MRI. Blood takes a characteristic almost entirely similar to prostate cancer. Moreover, since the prostate cancer show high signal intensity in the dynamic contrast enhancement, and so post-biopsy focus of hemorrhage may occur and cover the malignant lesion and cause an overestimation of its extension or mask the area of suspicion. So what's the resolution? If the patient come after doing biopsy and there is hemorrhage, the solution is the T1 weighted subtraction sequence in order to see the hemorrhagic sites. And in this condition, in this case, here is the hemorrhagic sites and the T1 weighted images, but still this area is void of the high signal intensity because this is a presence of a suspicious lesion, focal lesion, which shows a restriction diffusion, a low signal T2 weighted images, and this sign known as the hemorrhage exclusion sign. The most important mimicker is the chronic prostatitis or prostatitis. Prostatitis appears as acute, chronic, or even granulomatous. It can happen as diffuse or focal lesions. May occur as affecting both the peripheral zone and transitional zone. It's one of the most common prostate cancer mimics, and it may be impossible to reliably distinguish from cancer only on MRI, which make prostate inflammation a major source of false positive results on MRI. This is prostatitis, linear, radial. This is another prostatitis. This is another focal prostatitis. All say the same, looks the same. Chronic prostatitis, and in this case, this is a case of PSA 24 nanogram, and the PSA density was 0.5, and as we see here, ill-defined diffuse hypointensity, two-weighted signal in T2. Hypointensity is well seen, and some contrast enhancement, and so restriction in the diffusion-weighted images. Same in this case, still ill-defined, big amount of large big hypointense lesion in T2 weighted image, and so show some restricted diffusion and contrast enhancement. So chronic prostatitis can appear diffuse, lobar, or linear, while with the indistinct border rather than being focal, rounded, or over as in cancer. Therefore, the patient clinical history and follow-up after treatment are crucial in making the proper diagnosis. The big mimicker. Prostatic abscess has to be in mind because it develops as a complication of biopsy, prostatitis, or even after the treatment with intravesical BCG therapy. It frequently affects men with diabetes or immunotherapy. MRI, it will show high signal intensity in T2 weighted images and maybe low signal intensity in C1, and it shows a very restricted diffusion in the diffusion weighted images and the EDC. And when giving a contrast enhancement, it will give us a marginal contrast enhancement. So put in mind that prostate abscess is a big differential diagnosis from the cancer. However, because of the restricted diffusion in this area is too good to be true, have to put in mind the prostate abscess be the problem and not the cancer. Give contrast enhancement. I will show you the marginal enhancement of the lesion. And at last, the susceptibility artifacts, and this is the last artifacts, or this is the last pitfall problem in prostate MRI imaging reading, is the most important two that we're going to talk about is the one which are a metal artifact and the other one with the air artifact. Metal artifacts can happen in any patient with like prostatic prothesis or interventional procedure. It may mask or it cover the image of the prostate area, and the air in the rectum may not let us see the diffusion weighted images very well. What to do? Let's see it. The most important two is the metal artifact reduction and the air artifact reduction. It is advised to use 1.5 Tesla, not 3 Tesla in metal artifact reduction. It's advised, do not do the diffusion weighted images in a non-fat suppressed diffusion weighted is better. Metal artifact reduction sequence is needed and radial acquisition of diffusion weighted images is needed. This to help us to exclude the metal artifact reduction. While in air artifact reduction, we can overcome this artifact by doing a bowel preparation for the patient, by radial acquisition of diffusion weighted images, or right to left phase encoding, and sometimes they do the prone position for this. However, the prone position needs time because you have to get the patient from the bed and again return back the patient to the bed and then put the coil again, and sometimes it gives you bad T2 weighted images, so prone imaging of prostate is not preferable. And at last, I would like to conclude what I said, all of them, that MRI image of the prostate is not easy. It's a complex one because of the anatomy, because of the variability, and every lot of things. So we have a lot of pitfalls in the MRI. However, the most important issue is that please do MRI before that you take the biopsy, because it helps you a lot in detection of the lesion and reveal the dominating part of the cancer. Again, systematic approach reading of each sequence and plane is important, and to necessitate knowledge of normal variants like as I said before. Knowledge of known pitfalls of benign mimics is crucial, especially the normal anatomy, central zone, anterior fibromuscular stroma, transitional zone. Abscess is a differential diagnosis for restricted diffusion, and at last, take care of the image quality, which is of vital importance when doing the MRI imaging. Thank you very much.
Thank you, Professor Manal, for the very elegant and illustrated presentation. Any questions from the